is Lefebvre. I'm an addiction medicine physician, probably been in practice now in addiction medicine for about a little more than 15 years. And originally from Montreal, and did the first part of my medical training there. And that's really where I became interested in addiction medicine, not actually at McGill where I did my medical school, but in an elective that I did in my last year of training when I was planning to apply to family medicine and sort of exploring what other sort of subspecialties lay within family medicine. So I came to Toronto and at the Center for Addiction and Mental Health just spent a couple of weeks, but with some wonderful people who really were pioneers in addiction medicine, like Mel Kahan and Kay Shen and Michael Lester, and some lovely colleagues, Peter Selby as well. And just I was really intrigued in this area of medicine that was a blend of medicine, both physical and mental health, but also included a lot of advocacy work, a lot of education, and was also at the time and still really an emerging area where there was a lot of room for growth and a lot of room for innovation and a lot of really passionate people doing that work. And I was just very inspired by them, and I chose to continue my training in family medicine at U of T for that reason, and picked St. Joseph's Health Center as my site because I knew that Dr. Kahan was there, a lot of addiction medicine was happening there, and went through my training being further exposed to more of that, which just piqued my interest further, and then ended up doing a fellowship at CAMH actually, and started to work there. And that's sort of the beginning of everything, so to speak.
So during your time there, is there any incident or any experience that you had while you were there that stuck with you to this day that kind of really swayed you and say, yeah, like I want to commit to this, and I want to really dive into addiction medicine specialty?
It's hard to pinpoint like a singular experience. I mean, there were so many patients with such unique and sad but also inspiring stories who did well, and we were able to follow patients over time, which is something I love about addiction medicine. Is it's not just we see you for a brief period and then I have no idea what happens. That happens too, but often we're following people longitudinally, developing relationships. So that was important, in that it was not just a consultation specialty like cardiology where I see you, I diagnose your problem, I do a test, we kind of fix you, or maybe surgery, we fix you, we send you off on your way. It was something where we're constantly working through different challenges and developing those long relationships with patients. But another aspect of it was a new field. So whenever anyone would ask me, what do you do? And I would tell them, and then they would say, what is that? I think it's a bit more common now that people know a bit more about addiction medicine. But at that time, not so long ago, people really had no idea what it was, both within medicine and outside medicine. So I would explain a little bit what it entailed and sort of what types of things we would provide treatment for. And sometimes I would get reactions of support, and sometimes I would get reactions of, why would you do that? Like, that is the hardest medicine, or why are you investing in those people? And I think those type of reactions were actually what drove me to further commit to the field, because I was saying, I think this is very worthwhile. And it was a little bit about sort of proving to others that this is a worthwhile investment. There's a lot that we can do within the field. There's a lot of progress that can be made, and that anybody is worth investing in, but particularly people with addiction problems, given a lot of the factors that contribute to substance use disorder are things that we're not properly attending to in other sort of parts of our society. So I feel like there's some moral obligation there within my field of medicine to try and do what we can to help people. We can influence some of those other spheres, the other sort of social spheres, justice, those kind of things, but we can't directly influence them. We can directly influence the medical care and then attempt to influence the rest of the system. So it just seemed to me like, why would you not invest time in this area that's so ripe has so much potential and so much need that the patients, required. So part of it was that. It was a little bit of my kind of, I don't want to call it oppositional, but a bit of like, let's do something different than what is the easiest kind of most generic path in medicine. Let's find like an interesting kind of new area where there's a lot of potential for change, a lot of potential for innovation, and almost prove those people wrong who say it's not worth investing in this area or in these patients, because it totally is. And you can see how much the field has evolved even over the last 15 years and how much progress we've made. There's so much more to make. but how much of an impact the field has had even just up to now in the last little while, and how many more people are so interested in it within medicine. When I first started in the fellowship program, we were getting trainees who would come sort of like by circumstance, like maybe their partner was doing a fellowship in something else, and they said, okay, this is interesting, but they weren't necessarily having that in mind as their sort of goal for their career. Well, that changed dramatically, I would say 10 years ago, where the trainees were coming in with a very focused interest in addiction medicine, really seeing this field as their career goal, and the fellowship started to become competitive. So we hated ever to turn anybody away, and usually we'd find some way to include them, but it started to become not just something that people fell into, but something that people knew about, and they were going with that focus in mind into their training, which was so exciting to see. And now we still need a lot more addiction medicine physicians and addiction clinicians in general, but we have a lot more now than we had 15 years ago when I started, when I could count like on a couple hands, the clinicians who are really committed to addiction medicine, let's say within the GTA, and now there's hundreds, if not thousands, across the country. So that's really exciting to see. What does a positive way forward look like in terms of improving addiction medicine care? And one aspect of it, I think that at a high level, we could take a bit of a different perspective on is, instead of seeing addiction as a kind of one and done, like acute illness, and putting into place treatment resources accordingly, kind of time limited, very focused, and look at it more as it sort of naturally evolves, which is really a relapsing, remitting condition. Very different course for each individual, of course, but building in some more long-term supports that are flexible. So when things are going well, you don't have to completely disengage from the addiction treatment system. You're still a bit connected, so that if you do encounter a challenge, you can quickly be connected to a slightly higher or much higher intensity of care, rather than having to wait a long time. We can intervene more early if there's a problem, not letting it get so severe where people end up in emerge. I think cost effectively over time, this would bear itself out. It's just with the current way we plan our healthcare, which, we just came out of essentially an emergency situation, so fair enough. But we've always been fairly short in terms of our cycles of how we plan things. And if we could look a bit more with a longer view, and build a bit more coordinated system where people could be followed at a low intensity when they're doing perfectly fine. But if something comes up and they're put at risk for relapse, they can quickly kind of intensify their treatment and then back it off when things are more stable, rather than now we're letting fires get really big and then kind of just trying to throw a little blanket on it, and maybe it gets better temporarily, but we don't fully get someone back into remission by having those sort of brief interventions only in severe situations. We really need to build a more flexible, longer term, more responsive kind of approach to this. COVID was a huge challenge, as we acknowledge, across the whole population for a variety of reasons. We saw definitely an increase in substance use. There's some Ontario-related data with respect to alcohol in particular. And of course, sadly, the opioid numbers have just continued to go up as they do year over year. I think one of the biggest challenges with COVID was the isolation, which we know does not contribute well to the disease of addiction, both from peers and family members, but also from treatment supports. So, in-person mutual support groups are now online. For a small majority of people, that's better for a few different reasons, but for the large majority of people, it's probably not better. And they're just haphazard, day-to-day social interactions are way down. And some people will describe addiction as like a disease of lack of connection. I don't think it's that simple, but I think connecting and being with peers and with others is helpful in terms of anyone's well-being, but particularly if there's a substance use disorder in the mix. So it was a huge challenge. There were economic challenges, of course, in terms of people's financial situation, food insecurity, which is continuing on as we experience inflation. But I think the key was a lot of people were suddenly not able to access the supports that they typically would. And so that meant relapse for some people who had previously been using substances, and that meant actually turning to substances as a new way of coping for some people. Some people initiated sort of substance use disorder during the time of the pandemic. And now we're sort of picking up the pieces. We would have loved if we hadn't had the pandemic to take all that money that we spent doing that and invest it. My genie in the bottle would be invested in addiction care, but we can't do that because we're really trying to recover the health system from the huge expense of that. So we were already underfunded before, and that's just sort of continued with the increased incidence of people using substances to cope with all that was going on during the pandemic. And then my sort of focus in the last, focus in the last little while has been substance use disorders and mental health in healthcare workers. So I think that bears a sort of special mention in terms of the challenges that they would, of course, have experienced the same challenges as the rest of the population: isolation, fear of getting ill, but compounded by the fact that many of them are still going to work in person because some things you just can't do virtually in healthcare. And the fear of catching COVID or having to work really short staff because so many people are in quarantine because of those long periods of time for quarantine, getting ill themselves, trying to keep themselves isolated from their families, which further compounded the isolation. So some sort of special factors there. And I think we're still recovering from that. We've had people leaving the health profession just because of the stress of that experience. And that does not help our problem. It sort of is a catch-22 in terms of the short staff problem, because people are more short-staffed because now we didn't just have people in quarantine, now we have people who've potentially permanently left the profession, leaving everyone else who's still there short-staffed and overworked. So I am sort of quite concerned about that, and I hope we can improve our human resource capacity so that the people who are still working aren't so burnt out. And we know that burnout does put people at risk for substance use and other mental health problems. Burnout itself is not a diagnosis, but it's certainly a collection of symptoms that are not healthy and can predispose people to other problems emerging. I think even pre-pandemic, the way I would sort of best describe my recommended approach to not burning out is to have a good sense of your personal capacity of what you can handle, which you can only sort of develop over time as you sort of learn that in practice. So that can be hard in the first few years. And trying to combine that sense with good personal boundaries, whether that be with sort of what you can set up in terms of patient expectations, but also colleagues, and respecting each other's boundaries. So it's this complicated dance and interplay between other people's boundaries and your own, and having a sense of what your capacity is. So from my perspective, I sort of developed this before I knew I had developed it, in the sense that one of my core values is always honesty, and I always had a generally good sense of how much work I could do. So I never wanted to promise something to someone that I didn't think I could follow through on. So if I was saying yes to you, I was really making a commitment to follow through on what I had said yes to. So I think that was sort of the beginning of having good boundaries, and not everyone always likes it, certainly. But I always say to people, better to commit to a certain amount of work and actually do it rather than overcommit, and then you're burnt out and you're off on leave and you're not helping anybody. So I always sort of play the long game. It's the same when I'm sitting across from a physician or a nurse trying to talk them through what to do about their substance use disorder. Like if it's active right now, nobody really wants to step away from their practice. People love their practice. There's sometimes financial and other reasons, or they don't want to burden their colleagues. People don't want to step away necessarily to get treatment. But we try to take the longer view, that if we take some time now to properly deal with whatever it is, that the idea is we want to have them back and stay back, not have to take another leave or whatnot. So it's a bit the same approach to myself. It's sort of, we're going to try to commit to a workload that's sustainable in the long term. That may mean at times telling people I can't do X or I can't do Y. And I think it's acknowledging that as much as we want to help every single person, certainly in healthcare, the need is almost endless. So better to be there and doing what you can for a long term. You're of no use to anybody if you're not there at all. So it's sometimes hard to accept that, because we want to help every single person. Like that's often what brings people into healthcare or the helping professions. You just don't want to walk by someone who needs help anywhere. But at the same time, we want to take care of ourselves. We want to be there in our chosen profession, hopefully for long term. And I think taking that longer term mindset allows us a bit of permission to say no occasionally to things at the present time, so that we can say yes to other things for a longer time going forward. I mean, sadly in our field, the risk of mortality is quite high, and we do lose patients. Sometimes we don't know at all sort of what happened. So in that sense, it's a bit unsettling because we like, generally for closure, you like to have answers. So I think there's a few losses that come to mind where you're kind of constantly revisiting, what actually happened, how did that person's last hours transpire? Hopefully they weren't suffering, those types of things. I think as healthcare workers, we're always thinking about, is there anything that I did wrong? And is there anything that I could have done differently to prevent this from happening? And I think those reflection exercises are useful if you kind of can come up with some things that you would do differently, but at the same time, recognizing that some things just can't be prevented and we can't take the burden 100% on ourselves, which can be very hard for some people. In my work with physicians, we see, when they lose a patient or when they have a bad outcome or when they have a complaint, it's really distressing. It really shakes them to their core. And a lot of our training is around being perfect all the time, which is not sort of tenable. It's a bit of a setup for failure, and that no one is perfect. And some of those losses in terms of healthcare workers who've lost their lives, whether it be by suicide or other circumstances, especially when it's in the face of a bad outcome or something else that's really stressed them, are to me doubly tragic. I mean, everyone passing of anybody is an absolute tragedy. But when it's happened under those circumstances, when it's been related to a bad outcome or related to suicide, those are the harder ones to take. Because I feel like in an ideal world, we would be able to prevent all of those and like catch people and not have them feel like they have to be perfect, and support them going through some of those difficult situations that they do throughout their profession. There's a fair degree of trauma, as you mentioned, in being a healthcare worker, and not a lot of support sort of proactively provided. It's better now. There's been some peer support programs that have been developed in the last 5 or 10 years that are quite effective, actually, intervening in situations like that. So some of the losses for me have been those ones. Losses of colleagues, losses of other healthcare workers related to mental health and addictions. And also losses of some of my patients where there's sort of more questions than answers. And I would love to know for closure, just to know what happened. And I have to sit with that uncertainty and accept that. And it's hard, although it can be done. And at times, of course, you think of people who've passed and they just come into your head for whatever reason. And I think it's just, sitting with that discomfort, but accepting it and sort of, remembering the good things about that person. And I think grief is an evolving thing for our patients and for people who are close to us. So there's no perfect answer, as you can imagine. Then I think it's different for everybody. And having been doing this for a while, like I would say, it's not been 4 decades, but it's been a while, you sort of pick things up along the way. Especially if you get to meet the same patients over time through different circumstances. Sometimes it surprises you where you kind of come into contact with people again. And one thing that's always struck me is, first of all, it's the patient's life. So they're kind of in charge of the trajectory. We can provide advice, but ultimately they're going to decide what to do. But you don't always see those immediate sort of impacts. But you see them often enough, I think, that they keep you moving forward. So I always think it's always worth putting in the time, doing the right thing, because even if it seems like it had absolutely zero impact today, sometimes you'll speak to the patient years later and they'll be like, I remember that time several years before, and you probably don't even remember that you said it. You said X, Y, or Z, or someone else said it, and it had an impact. So it's like you kind of are throwing the goodness out there and you're not quite sure where it's going to stick. But I think it's worth it. I think more often than not, the impact is there, even if the patient doesn't know it at the time, that it may plant a seed for further down the road or whatever it may be. So it's sort of trusting, having faith just in general, that it's always worth to put that effort in. And I think our field is one where we get a lot more, actually, of the positive immediate impact than other people get. I think we sort of maybe sometimes miss it with some of the more serious and sad situations that we deal with. But that's one thing I liked about addiction medicine is in certain circumstances, we can stabilize people with intense care like really fast, versus some other illnesses where the treatments aren't as effective or the change doesn't come as quickly. And yes, there are definitely situations where it seems like we're doing nothing, but it's interesting to see over time how what we think had no impact actually did have an impact. But it's always important also not to be pushing the patient too hard, because I've seen that backfire too. So it's this delicate dance between not doing nothing and waiting for everything to fall apart, but not pushing too hard. And that takes time to sort of develop the comfort to know when to do it. And we still make missteps, but you do your best job at any time. So, harm reduction writ large is, as it sounds, it's trying to reduce the harms of substance use, whether those be harms to your physical self, such as infections and bloodborne pathogens, or harms to you as a person, whether that be through interactions with the criminal justice system or other social services or whatnot. So it's expanded a little bit beyond its sort of initial mandate, which was really to prevent the spread of HIV, and the circles have kind of come out from there. I think, like anything, it's generally helpful to look at addiction care as a spectrum. So in the past, I think perhaps a little less so now, although it waxes and wanes, there have sometimes been sort of people who've decided this ideology or that ideology is kind of like how I'm going to approach this problem, and I'm going to kind of stay wedded to it. And I prefer to think of it as a spectrum. So for example, when I first started practicing at CAMH, we were prescribing opioid agonist therapy to our patients with opioid use disorder, which is absolutely the standard of care now. It was the standard of care then. It wasn't very widely available. And what we were doing by some was construed as like, why would you give people who have problems with substances to help them? Like, the solution is no substances. So it was like abstinence versus what we were doing. And so what we were doing was really painted as harm reduction, whereas I thought of it just as a treatment option. And this is a treatment for this disorder. We don't need to kind of decide whose ideology, which intervention fits in, and like whether it's okay or not. It's just different things that could help the patient at any given point in time. And so it's sort of been a moving target as harm reduction has expanded. Now that which was considered harm reduction previously is now part of like the core of good treatment. And there are some other interventions that have emerged that now people would say are sort of more under the umbrella of harm reduction. And I think the key is to always be looking for any interventions that can reduce our patients' risk of morbidity and mortality, so like bad things happening from their substance use disorder. And whether we call them X or we call them Y, sometimes is not helpful in terms of if it's going to be tied to a certain ideology of what is acceptable or what is not. So it's a bit of a moving target, and I prefer to look at it as a spectrum of different things that the patient could benefit from at X point in time, and we pick and choose from the tools that we have and use them for the benefit of the patient rather than thinking in one particular ideology versus another, and then trying to get the patient to sort of fit into our conceptualization of what's going to be helpful. So one particular sort of story, and this story repeated itself a few times after the first time it happened to me, would be providing support to a healthcare worker who's calling and doesn't even want to let us know their name. They're so scared that anyone would find out what's going on. They're literally anonymous, which is fine. And providing sort of care and advice to that person as to like, what are the next steps? What do you do? They're so terrified. They're terrified they're going to lose their career, family, whatever it's going to be. They don't want to tell people. They're so ashamed of what's happening. And walking that person through from that stage through to getting treatment and ongoing follow-up. Obviously, at some point, I know who this person is. They reveal their identity and they're feeling comfortable enough to no longer be anonymous. And we walk them through treatment, taking some time away to get well and back to practice. And they're like a superstar in practice once they return, because they've sorted through several sort of long-standing issues that have contributed to the substance problem. And they've really managed to turn their life around. And everything that they were fearful of, none of it happens. And, only more good things happen after they're well and back to practice. So those and having those, I remember one particular individual coming back, and I'm privileged enough to have heard this several times in my career and being like, you literally saved my life. Like, if we hadn't done that, the chances that I would have been dead were, they acknowledge fairly significant. And so going from having someone who's so scared they won't even tell you their name to sort of holding them through all that and having a really good outcome at the end was, I don't think a lot of people get to experience that. So I found that a hugely profound privilege to walk someone through from that level of distress to an amazing outcome where they're just an absolute star and living a very meaningful life and feeling well and healthy and all the good things that come from that. So that had a huge impact.
It's super inspiring. And I think more people should, I understand why some people don't want to go back and revisit it, but I think hearing stories like that can be the difference between someone's paradigm shift and how they view their ability to kind of come back from it.
And one thing that we do from time to time is connect people to peers, because like you said, I'm not in recovery. So my experience, although I've had a lot of experience talking with people who've had substance use disorders, I recognize it's not the same as speaking with a peer who's actually been through it. So we provide what we can and we give them tools and options and whatnot. But sometimes it's just that conversation with the peer who's been through it and has done well for so long to reassure them that this is all I can say till the cows come home. This is going to be fine. And I know it's going to be fine, but it's getting them to believe that I actually know that. And so being able to speak to a peer who's been through that is hugely valuable. And sometimes that is truly the turning of the key. That's like, okay, I can put my trust in these people's hands, when I'm at my most vulnerable, and trust that we're going to get there together. But it's really scary, and taking those first few steps is the most scary. So I've seen so many positive impacts from that peer discussion. That's just so valuable, both in my health professionals work and just in work with all patients. Like you said, connecting with them and being able to share that common experience, there's something very special about that. I would acknowledge that it's hard and scary to take that first step. And it's very hard from the first step to see where the journey goes. But I can almost always reassure them that getting the help and speaking to someone else about what's going on is less scary than you think it's going to be and will lead to better places. But I want to normalize the fear of reaching out, but the importance of getting help, because I've seen even the most absolutely brilliant and skilled people try to manage substance use disorders on their own. It's extremely difficult. It's sort of the nature of the illness is such that you can't really manage it on your own. You need the support of others, whether it's professionals or not. But staying alone in isolation is a hard place to be. And that first step in reaching out is really challenging, but help is available. Once you tell someone else, it takes a bit of the burden off yourself, and it becomes easier to tell that next person and hopefully get to the care that one needs. I think the key is to always, it's going to sound very cliche, but always keep a learning mindset and always stay open-minded. And don't feel the pressure to always have all the answers yourself at any time, because we don't, and we can't put that pressure on ourselves. It's not fruitful. So whether that's talking to a mentor or a colleague or whoever, speaking to others, not trying to feel the pressure to do everything yourself, and also speaking to the patient. I can't tell you how many times I haven't been quite sure what the next right step is. Well, the natural person to ask is the patient, sort of where they're at and what they're thinking through. And that gives you, if you're not quite sure what to do next, somewhere to start. And it's really important to include the patient's perspective in what we're going to do next, not just be telling them to do X, Y, or Z, but really be checking in and kind of crafting that plan together. It makes a better plan because the patient is involved, and it takes some of that pressure off that you feel to always have all the answers, because this is not just a medical sort of solution, generally speaking, to addiction. There's some medical treatments, but there's also all kinds of other things in the patient's life that we need to think of and sort of creatively work through, whether they're challenges or strengths. And that comes through conversation and getting to know people and sort of checking in where they're at and working from their ideas. So many times I've been stumped and not quite sure where to go next. I know kind of what the medical treatments are, and we can do those, but I know they're not 100% effective and not going to necessarily change things around. We have to do other things, and those things tend to come from the patient. So taking a strengths-based approach, as we call it, not so much dissecting what went wrong with the relapse, but more what went right in the times when you didn't use, and how can we do more of that instead of focusing on doing less of what contributed to the relapse, which is beneficial but not always so fruitful.
What do you use to cope? what are your coping mechanisms? That when you've had a particular day where you're either overwhelmed or something, you've lost somebody, or whatever that day is, and or when things are going great. Like what are the ways you manage things you utilize just to kind of stay level?
I think there's sort of like proactive and reactive things that you can do, right? So one proactive thing is, having a varied life, so that if you have a challenge here, it's like not the sum total of the entirety of your life, and it's not like the whole house of cards falls apart, which we do sometimes see in medicine, where people's identity is like just being a physician, and if anything goes wrong there, they don't have much to fall back on. So having a varied life where you have your job and other things that you like to do, whether it's leisure or other projects or family or whatever it may be, so that there's a variety of things going on in your life, so that if there's a challenge here, you have other things that are hopefully going well to sort of fall back on. So that's sort of proactive planning. I think staying connected to others, like for me, that's so important. That's why I like to follow patients long term, and that's why I value sort of meeting all different people and hearing their different perspectives. I think it just keeps you grounded and knowing that there's all kinds of variety of things out there, and that if you may think that this bad thing that happened is kind of like everything is over now, it widens your view and you get a bit of a bigger perspective to see that maybe that's a challenge, but it's overcomable and it's not the sum total of everything. You have other good things to lean back on. Good things like exercise, sleep, it can't be overstated, the importance of those that are hard when you're busy and there's all kinds of other interesting things to do, but just sort of keeping regimented about the things that keep you well. So it's different for different people, but for myself, it's exercise, sleep, making sure I'm connecting with other people, making sure I'm not over-promising and under-delivering so that I feel like I'm not disappointing people. And self-compassion. Like even with best laid plans like I just outlined, it's not always going to go the way you wanted it to. And being okay with that and not always trying to put the burden on yourself for something that goes wrong. Having some compassion that you tried your best, just like you would tell your friend that they tried their best, and trying not to be too hard on yourself, which is not always easy. A couple of key things in terms of surviving a career in addiction medicine, although he painted out to be terrible, and I think it's actually like an absolutely wonderful specialty, but it has its challenges, and like you said, that comes from, unfortunately, the difficult experiences of our patients. I certainly don't want to make it all about us, although we have to acknowledge kind of how do we as professionals move through that. But it's the patient who's generally experienced the trauma first, which is terrible. I think obviously coming in with an awareness of that, and coming in with an awareness of how trauma impacts the patient, but also how it can impact yourself, is important. So things like having some training in trauma-informed care and sort of knowing a little bit about trauma treatment, even if you're not going to fully provide it, is important. And the aspects of sort of repeating trauma narratives and how that can actually negatively impact you and the patient. So just being aware, when someone's coming in and they're very much in an active stage of addiction and possibly don't have a lot of great emotional regulation skills, going through a whole litany of traumas is not going to be helpful to them or to you. So it's acknowledging it, not trying to avoid it, but also not trying to reopen it until the patient is ready to talk about that content. And also talking about very traumatic content obviously can also have an impact on the clinician. So it's having an awareness about trauma treatment and how doing it properly both protects you and the patient from further traumatization. Then the other major thing I would say is having a good mentor or set of peers that you can bounce ideas off of, which is good in all of medicine, but particularly good in our field. We're fraught with sort of moral dilemmas and really difficult situations or decisions where there's not necessarily one single right decision to be made, or there's multiple ones that have to be made at the same time. And speaking to others to get a different perspective, or maybe a more seasoned perspective, super helpful, or even just to be able to share something difficult with someone else with no expectation necessarily of any next steps, but just being able to share and not have to hold it all to yourself. So I think that's key, is having a community of others that you work with It helps improve your practice, but also helps keep you well, and for the clinician not to feel isolated. We talk about important for patients not to feel isolated and how isolation isn't good. It's also not good for us to be isolated. So practicing in a group or having a group of peers that you meet with is super helpful in terms of providing that support and mentoring others more junior to you and being mentored by others more senior to you until I suppose you get to a certain age when everyone else is retired. I'm not there yet. Is really valuable. And I still, even though many people call me for advice, but I also still call other people for advice, whether it's clinical, like I'm not quite sure what the next best step is for this situation, or if it's just to describe a difficult situation and just have someone to sort of vent and talk to it about. So having mentors or having peers, really important. And I think coming back to what we chatted about a little bit earlier, which was around boundaries, having compassion for yourself that we're only one person, we can't boil the ocean. Accepting a reasonable amount of workload and doing it well versus accepting too much and feeling like you're failing on all fronts is sort of a good life lesson, but it definitely applies to the practice of medicine or any healthcare profession as well. And respecting others' boundaries. It sort of goes both ways. If I'm going to ask you to kind of respect my boundaries, well, if you set up a limitation that's important for your wellness, I need to respect that as well. And that's kind of how we all prop up sort of the house of cards, so to speak, is by mutually supporting each other. And our professions don't always set us up well for that. They're quite individual achievement focused. I think it's changing, but I think it still bears more attention in terms of how we support each other and don't sort of work in silos and work in sort of competition with each other. We're all here with the same goal in mind, and the way that we get there is by working together. So those would be sort of my top three.
Yeah, and I'm not trying to paint all of it as too blue, because I mean the most beautiful experiences of my life have come as a result of having that.
Right.
So but I mean, there's also the counterweight to it, though, that it can be a very dark place.
Yeah.
But, it can go either way, really.
Yeah.
It's just,
and I think one other thing which could be in those top three is like maintaining hope and optimism. I think I've always been a generally pragmatic but optimistic person. And I think never losing sight of there's no situation that's like absolutely hopeless. And one of the things that being in practice for a while helps you develop is sort of seeing things suddenly change, sometimes for nothing that I did, just some other external circumstance, and something that seemed like it was going to go on in a negative trajectory forever suddenly goes on a positive trajectory. So one of the things I learned early on in practice was I would sort of think something was going to go this way, and whether it would be good or bad, and then suddenly we're in this other place. And so it can be a bit jarring at times, but always just keeping this optimism that something bad can suddenly take a turn for better. And sadly, yes, of course, something that's going well, we always have to kind of keep a healthy awareness that we could go off the rails and try and guard against that. But being okay with uncertainty, I guess. It's not always going to be like from A to B to C at all. But it's not always going to be a negative, unexpected trajectory. There's also some really kind of fun and exciting, positive, unexpected trajectories that people go through, which those are my favorites. So I would always say, you kind of think you know what's going to happen, you think it's going to be like this, like just throw all that out the window, because it could go this way or it could go that way, and you just kind of have to keep an open mind that either of those two things could happen at any given time, and sort of approach the situation appropriately.